If your sternum's overlapping the spine, your image is lying. Let's fix that. Today, we're covering a really important but often overlooked area in thoracic imaging: the sternum, sternoclavicular joints, and ribs. Whether you're brushing up for your ARRT CQR Structured Self-Assessment or just trying to improve your positioning game, this video is for you. We're going to walk through each projection step by step. That means positioning, exposure technique, anatomy labeling, image quality criteria, and common mistakes. For each view, you'll get 2 slides, one for setup and one for evaluation. Let's dive in. Let's start with the RAO sternum, the classic projection that projects the sternum over the heart shadow to avoid the spine. Here's how you set it up. The patient is erect or prone, facing the image receptor. Rotate the patient 15 to 20 degrees into a right anterior oblique. The CR is perpendicular to T7, which is about 1 inch lateral to the MSP on the elevated side. Use a 30-inch SID if possible. This helps increase magnification slightly to improve visibility. Collimate closely to include just the maneuver through the xiphoid process. Use a breathing technique, shallow breathing, to blur out lung markings or a short exposure on expiration if needed. Your exposure technique, you want to use between 70 and 80 kVp, a high mass, and a grid is recommended. This projection is especially useful for trauma or pain localized to the anterior chest. Now let's evaluate it. The sternum should appear faint but visible over the heart shadow. Look for the manubrium, the body, and ideally the xiphoid process. Key image quality checks. The sternum should be to the left of the spine, superimposed over homogeneous soft tissue, not over vertebrae. If it's too lateral or too medial, your rotation angle needs adjusting. Slight motion blur is expected if using a breathing technique, but sharpness of the sternum itself should still be adequate. Look at contrast. Too much exposure and the sternum disappears. Too little and it's noisy. Next is the lateral sternum. This one requires the patient upright and their left side to the IR in a true lateral. Shoulders are drawn back, arms behind the back or over the head. The CR is perpendicular to mid-sternum, which is around T7. We use a 72-inch SID to reduce magnification, and we suspend respiration on deep inspiration. Collimate tightly to the sternum, but make sure you include the entire length. Use 75 to 85 kVp and a high mass. Again, a grid is required. So what should you see? The entire sternum should be in profile, no rotation, no overlapping ribs or arms. Look for clear bony margins. Manubrium, sternal body, and xiphoid should all be visible. Overlapping lung markings should be minimal. If the sternum is overlapped by ribs or the spine, check patient position and rotation. If the xiphoid is hard to see, don't panic. It's often faint depending on the patient. Now, on to SC joints. First up is the PA view. Your patient is prone or upright and facing the IR. The MSP is aligned straight. No rotation. The CR is perpendicular to T2, T3, which is about 3 inches below the vertebral prominence. Tightly side to side. Expose on expiration to bring the joints closer together. Use a 70 to 80 kVp, moderate mass, and there's no grid required unless the part thickness exceeds 10 centimeters. On a well-positioned PA image, both SC joints should be visible and symmetric. Medial clavicles should be equidistant from the spine, meaning the same distance. Rotation shows up fast here. If one joint looks wider than the other, your patient isn't straight. Let's isolate each SC joint using an oblique view. You want to rotate the patient 10 to 15 degrees towards the side of interest. So for a left SC joint, use LAO. For the right, use RAO. Your CR is still directed at T2, T3. You expose on expiration. You collimate to include the SC joint and medial clavicle. You're going to use the same exposure technique as the PA view. In oblique, the SC joint of interest is open and free of spine superimposition. You should also see the adjacent clavicle head and upper ribs. If it still looks closed, rotate more. Let's talk about a trauma specialty view that isn't in the standard ARRT outline, but it absolutely matters in real-world practice: the Serendipity View for the sternoclavicular joints. This projection helps visualize vertical displacement of the SC joints, meaning if a joint is pushed upward or backward, like in a car wreck or contact sports injury, this is your go-to view. Here's how to set it up. The patient is either supine or upright, facing the X-ray tube. You'll need to angle your central ray 15 to 20 degrees cephalad. Some protocols may use up to 40 degrees, but 15 to 20 is the standard. Your CR is centered at the manubrium, right at the level of T2, T3, just above the sternum. Use a 10 by 12 crosswise cassette and tight collimation side to side. Ask the patient to exhale and hold. This helps bring the SC joints up and improves contrast. Exposure technique. You want to use a 70 to 80 kVp here, moderate mass, and the grid is recommended. This projection is especially helpful if you suspect posterior SC dislocation, which can compress the great vessels. That's an emergency you don't want to miss. All right, evaluation time. On a proper serendipity view, both SC joints will be visible and projected above the ribs and soft tissue shadows. Now here's the trick. Posterior dislocation, that joint will look lower than the unaffected side. Anterior dislocation, that joint will appear higher than the other. In a normal case, both joints should be at equal height. Asymmetry is your red flag. And just to drive it home, if you see any signs of posterior displacement, flag it immediately. Posterior dislocations are rare, but can be fatal if they compress the trachea, subclavian vessels, or even the aorta. This is a life-saving view, not just an academic one. All right, time for ribs. Starting with ribs above the diaphragm. You're going to have your patient upright. You will position them PA if they're in anterior pain, AP if they're in posterior pain. Your CR is directed to T7. You expose on inspiration to depress the diaphragm. You're going to use an 85 to 90 kVp here. A long exposure and a grid is absolutely recommended. Your SID is 72 inches for upright views. On your image, you should clearly see ribs 1 through 9 above the diaphragm. Ribs should appear sharp with good contrast. Sternum and spine should be in the midline. There should be no rotation. Next, ribs below the diaphragm. Your patient will be supine for these, and the CR is directed to T10. You expose on expiration to elevate the diaphragm. You're going to use a 75 to 80 kVp, a higher mass, and a grid. 40 inches here for the SID is fine. Ribs 8 through 12 should be clearly visible. The diaphragm should appear elevated. Soft tissue details should be preserved. To see the axillary ribs, use oblique view. You'll rotate the patient 45 degrees. If they're in posterior pain, we want to put the affected side towards the IR. If they're in anterior pain, we want to put the affected side away from the IR. Our CR is directed to T7 for above or T10 for below. Use inspiration for above and expiration for below. Your obliques should show elongated ribs of interest with minimal overlap. There should be no clipping, no foreshortening, and that's a wrap. You now know how to position, evaluate, and adjust every key thoracic image: sternum, SC joints, and ribs. This isn't just for the CQR exam. These are life-saving trauma views that you might be the first to perform in an emergency room. Thanks for watching Analyze with Casey. Subscribe, leave your questions below, and check out my full CQR study toolkit on analyzewithcasey.org. You've got this. Happy positioning.